My name's Beth Kidd and I work for Hub Cymru Africa. I'm just going to do a bit of housekeeping and then hand over to Dr Zed to start us off. So yes, welcome to recognising the contribution of NHS Diaspora staff to global health. Please can you make sure your name is in your Zoom window and your organisation if you wish to add that. You can do that. There's 3 little dots to the top right, I think it is, of your box with your name in it, and there's an option there to rename. We will be doing a poll at the end of the session, and there will be some feedback forms that we'll send links to. If you wouldn't mind participating in those, we'd be very grateful. It's always useful to hear your thoughts on how these events go, and we can take that learning forward to future events. We encourage you to actively participate, but you're not required to. If you have any questions, you can either raise your hand, either physically, or there is a little icon button at the bottom of your screen. If you click on that, there's a raise hand option. But you can also add any questions you have to the chat box, which again is on that ribbon at the bottom of your screen. And we will pick them up from there and come to those when we get to the point where we do questions. Due to background noise, please make sure you're muted unless you're actively speaking, so we can hear the people who are presenting. So this is a safe space. We ask people to listen without prejudice and with respect. We want to create a positive environment and for people to feel able to participate fully. If you have any serious concerns or need to make a complaint, if you go to the WCIA website and search for the whistleblowing policy, that will tell you how to do that. But we won't tolerate any abusive language either in the chats or in the sessions. So please be aware of that. The objectives for today's session are to raise the issues highlighted in VET's Experts in Our Midst report, to hear the experiences of these issues within the context in Wales, to start conversations with the key stakeholders and to engage our current stakeholders with new issues, and to influence global health developments and strategies in Wales. We will be going into breakout rooms later, and as you will have seen from the pre-event communications, there's 3 of those. We're doing one on diaspora contribution to global health with Kit Chalmers from VET, one on inclusion and health inequalities with Fidili and Faith from the Sub-Saharan Advisory Panel, and one on diaspora contribution to the NHS with Dr Zed, who is chairing this session. For those of you that have requested certain sessions, you hopefully will be in the ones you've requested, and everybody else has been allocated a session at random. So I will hand over to you, Dr Zed, if that's okay.
Next slide. Right. Welcome to all of you who have joined, and thank you very much for joining our shared learning event. And I'm sure some of you have joined some of the shared learning events in the past. And this is obviously from the Wales for Africa Health Links, but we are hosted and helped as we are part of the Hub Cymru Africa. Just introduction, my name is Dr. Swand. I'm a pediatrician, but I'm also a trustee for Wales for Africa Health Links. And I have a link with a Zimbabwe Health Link. So I'm really looking forward to this afternoon, and I'm hoping that you will enjoy it as well. And I'm quite confident with the faculty we have that we will enjoy. I don't think it would be appropriate for me not to highlight that we might have colleagues that are affected by the issues that are happening in Ukraine. I think it will be helpful for us as a group just to recognize that. I think Beth has already highlighted some of the key issues that we want to highlight in terms of raising awareness of issues highlighted in this key report that was done by VET, and we will be hearing a lot about it very soon. And we want to get some key issues about benefits to individuals, the NHS, and partnerships. We are hoping that as the afternoon goes, we will get some shared lived experiences in relation to challenges and barriers from individuals here in Wales and also from their country of heritage. We know that Wales and UK, probably we are one of the countries with the highest international group of health workers. They say 1 in 3 doctors and 1 in 8 nurses have been trained overseas. And we feel that they have a contribution, and this report seems to highlight that. Most of us, we have learned a lot in the NHS, and there's no doubt about that. And we have improved our careers, but we have always felt that our experience working in our home countries, that is low resource countries, has also brought a valuable contribution to the NHS. And this report recognizes that. And we are hoping that we can build on that, and we are trying to explore that this afternoon. Next slide. Just a quick through about the people that are going to have. We've been very lucky to have a very distinguished faculty of experts that are going to help us this afternoon. I will just briefly mention a little bit about each one of them, and then I'm sure they will tell us a little bit more themselves. Kit Chalmers is going to be the key speaker in terms of actually telling us about the report. She's head of policy and learning at THET. She has worked as an NHS consultant in Glenclwyd, and she has also been part of a link with Ethiopia. And she has led 2 Welsh Government commissioned reviews on international health. We are also very glad to have Ian Collins, who is an NHS psychiatrist consultant, and he's a director of medical and professional support and development at Health Education and Improvement Wales. And looking at his CV, he has a passion in terms of training and also supporting leadership in trainees, and he runs a leadership fellowship course. We've got Sue Tranka, who is Chief Nursing Officer, and I'm told she's the first person to hold that role from an ethnic minority background. She has worked as a Deputy Chief Nursing Officer in England. She has worked as a Director of Nursing. She has extensive experience at all sorts of levels. She has also got international experience, as she originally comes from South Africa. We've got Dorcas, who will be part of our panel as well, who is a public health specialist and from working in Northwest London, and a mental health and public health nurse, working with Westminster Council in multi-agency work with gangs unit there. She's also a trustee for the World Fund for Nature. Just to recognize the Sub-Saharan Africa team are going to be helping with the workshops. Sfadili, who is their Chief Executive Officer, and Faith, who is their Director for Diaspora and Inclusion. And also, we can't have a shared learning event without sharing from a particular link, and Betsy Kenya link will be doing that sharing. And I know that Fiona has already joined us, and we are also awaiting one of the members, and I'm sure they'll tell us a lot more about that. So I will hand over to Kit to kick us off now on that.
Thank you very much, Zed, and thank you for the introduction. It's always a pleasure to be speaking in Wales. I'm sitting looking out at a very sunny Llandudno here. So I am now Head of Policy and Learning at THET, and I should point out that really I'm in this position through my links to the Wales and Africa Health Links Network. So I'm here to talk about our latest policy report, which has sparked the current, this event, but of course covers issues that many people here have known about and many people have experienced for years. It was published in August 2021 and written by my predecessor, experts in our midst. And the tagline for it, if you like, is recognising the contribution which NHS Diaspora staff make to global health, because we know that they make a huge contribution to global health. And the report really looks at what that is and how that comes across in the work and what we can do to make things better. Zed has stolen my thunder here a bit, but just to set the scene, of course, the UK employs vast numbers of staff from overseas, and also staff who are British, but who have a connection to other countries. So these are NHS England figures because they're more difficult to come across for Wales, but 15% within England, NHS trained overseas. And so they're contributing to the UK health system in the same way that all other UK health workers are, by providing direct patient care. Many of them are also contributing to global health systems, some of them through health partnerships. And I feel that I maybe don't need to explain health partnerships to this audience, but perhaps I will very briefly just to make sure we're on the same page. So a formal health partnership is a long-term link between health institution in the UK and one in a low and middle income country. that works together in a bi-directional way to support each other in terms of health and health services. And THET and the Wales and Africa Health Links Network are focused on supporting those organisations. So some of them are part of formal health partnerships. Many have individual links and activities that are undertaken informally. And then there are all sorts of other things in terms of remittances sent back to those countries, and then skills and cultural knowledge, which impact on their work with global health systems, but also on their work in the UK health system, which I'll come to later. And it barely needs saying, but it always does, that health systems are interdependent. So in many ways, there's no point having a strong UK health system if other health systems are not also strong. And I thought that was the point when I was going to make a point about when this work took place, but I'll come to that. So this report, this is very much a high-level overview. It's quite a long report, but it involved a rapid literature review looking at what was already known in published and grey literature about diaspora contribution to global health. What we call at THET a public inquiries, so essentially hearing evidence, so talking to people in open events often, and hearing from people who have been impacted by this, who are part of global health and the NHS and their experience of that, and also surveys and follow-up interviews with health partnerships that we support and wider diaspora organisations. All of this guided by a steering group of experts, most of whom have lived experience, all of whom work in either global health or the NHS or both. And within this, we had to define diaspora. And we could probably sit here for 2 hours and debate what the correct definition is, but we settled on this as modern diasporas being ethnic minority groups of migrant origins, residing and acting in host countries and maintaining strong links with their countries of origin. The point in part being that we're not only talking here about people who have just arrived in the UK or have migrated, who've trained overseas and are now working in the UK, but also those who are second or beyond generation, but still have close links and close knowledge of their countries of heritage. So this work took place between 2019 and 2021. We all know what happened in the middle of that. In fact, it's the second anniversary of our first lockdown, isn't it? And so through the events of the last couple of years, this has almost suddenly come to the fore. And I realise that for many people here, they will have been living this for a long time. But for others of us, this has very much come up the agenda and right in front of our faces, the gross inequalities that have taken place within the UK and globally in terms of COVID, the Black Lives Matter movement, and a much greater drive for inclusion and equality in the UK certainly and globally. So we know that the NHS benefits from global engagement. We know that individuals who take part develop practical skills. These are UK individuals, practical skills, leadership skills, very much, knowledge, cultural competency, and that to the systems that they come back to, as well as those individual developments, they can introduce innovations and they can introduce a change in culture. And at THET, we've been aware that we think about British individuals going overseas and developing these skills, while we have a health system that's full of people who have moved from other health systems, who already have different practical skills, knowledge, cultural competency, who can bring innovations from the countries and the health systems they've worked in previously, and that we're probably not making as much use of that as we should do. And our report outlines what we found, but essentially that this is that expertise that those diaspora staff can bring to the UK is significantly underestimated and underutilised. And the same goes in the opposite direction. So those connections between those staff and their countries of origin is not supported in ways that make their work as impactful as it potentially could be. And these are fundamentally tied to the issues of inclusion and of leadership that are so sorely needed in the NHS and which are now focused on as opportunities for development. So staff who don't feel valued, from minority ethnic backgrounds, diaspora staff, if they see their work as not being valued, they feel excluded, they are excluded. And we know that some of this comes from unconscious bias, and we know that some of it comes from explicit racism, and we need to work to change that. And it's expressed in differential take-up of leadership posts by those diaspora staff who are significantly underrepresented at the higher levels of leadership. And of course, delighted to be joined by Sue today and breaking those barriers. So the recommendations of the report recognise that there is existing work on this. So particularly for nurses, and particularly within England, there's some financial support for diaspora nursing organisations, which has been very positively received and significantly improved, certainly the experience of diaspora nurses moving to the UK. That could expand to other groups, for example, doctors, allied healthcare professionals. But the recommendations also go further and think more about the benefits back to the UK and those global connections and making most of those for global good. So we recommend that health partnerships involve diaspora within their work, and certainly are diaspora-led where possible. Some of that depends on funding, and we know that some members of the diaspora are disadvantaged in terms of funding because of the nature of the work that they're undertaking, the perhaps informal nature of their work and the links, and also the structures around that and the inequalities around that. Recommendation for ourselves to create a diversity network, which we're starting to do now, to bring together NHS diaspora and diversity and equality leaders with health partnerships, using exemplars of trusts and boards that are leading the way in this. For UK and low middle income country governments to think about how to strategically use their diaspora, and many are, particularly in low middle income countries, but a lot more could be done on this. And we know that the Department of Health and Social Care in the UK is actually working on ways to better involve diaspora in their bilateral global health relations. And there are recommendations around alliances. So there are already a number of alliances, so groups of health partnerships and organisations within the UK acting within a single low middle income country. So for example, Uganda, more recently Kenya, Myanmar. And they're in an ideal position to lead development of greater links with the diaspora in the UK, to take part in that work and to lead that work and to bring what they know of context and culture to support that. So I'm going to finish there with this quote from Navina Evans, who is herself a diaspora and Chief Executive Officer of HEE, who funded this work, really just bringing out the importance of acting on this and acting on it now for the sake of the NHS and for the sake of health systems globally. Thank you.
Thank you very much, Kit. Really quite clear and concise. I mean, for such a long document, you made the summary really quite easy to follow. Thank you very much. I know that Sue has got time, very tight time, and she has to run away. So we will go straight to her talk now so that we can give her the opportunity to leave when she can. So can we go straight to Sue Tranka, please?
Thank you very much, Zed. So, Prananda Bob, good afternoon, everyone. And thank you to Zed for the introduction. I am the Chief Nursing Officer for Wales, a very proud Chief Nursing Officer for Wales, Welsh Government, and I am the Nurse Director for NHS Wales too. So it's an absolute pleasure to be invited to talk to you this afternoon. I'm really pleased to see that in this week that marks the celebration of elimination of racial discrimination, we're talking about health inequalities and inclusion. And in keeping with the findings of the third report, I think it's really timely we turn our focus to what can be done in Wales. And I'm most struck by the words of what can be done. I'm more pushed to say what we have to do in Wales to make the difference. I hope to share with you today what I hope to achieve as a CNO going forward. And I feel really strongly about making it better for those of us that do come from diaspora countries and have heritage outside of the United Kingdom. And you'll know, Zed just told you, I am the first ethnic minority CNO to hold this post ever in the history of this country. That is huge. That is really a momentous time, I think, for us, but signals a real change. And I feel that change. And I think it's important to be able to say that to you. Since arriving in post, my observations have been really about seeing me first. And that has made a huge difference to the way in which I operate. It's enabling me to be a chief nursing officer at the very best that I can be, but also helping me to do what I need to do. And I think those are the bits I want to talk about today with you. So to Kit, who talked about the 15%, yeah, well, you know, I'm one of those, and I just want to say thank you for the report. It was insightful reading and really, I think, something that will be needed to be used in the NHS to spur action. So when I read the report, I thought about, well, what do we know about racial inequalities in health in Wales, both in terms of our population and our health workforce? And I spent some time just looking at the data. So, and I don't want to replay the data because you'll know some of this, but I think there's some stark data that's evident, but also what's evident is that our data in Wales isn't as robust as it needs to be. And we acknowledge that, and we are doing some work. So I'll tell you a little bit about the work that we're doing. But when I think about the recent analysis around the ONS data that are published around the risk of deaths involving COVID-19 among some of our ethnic groups in England and Wales, we were significantly higher than those of our white ethnicities. And this difference was partially explained by socioeconomic factors, geographical location, and other circumstances. But a lot of that difference remains unexplained, or unexplained for those that aren't seeking to really understand. I'll remind you that almost 1 in 5 Asian and minority ethnic LGBT people in Britain, so not Wales specifically, but in Britain, and up to 23% of Asian LGBT people will have experienced difficulty gaining access to our healthcare services. 1 in 5 Black, Asian and minority ethnic LGBT people will have avoided treatment for fear of discrimination, but that they are LGBT. Our Gypsy, Roma, traveller people's experience of prejudice and discrimination is stark. It's based on an online survey of 214 community members, and we know that 30%, that's 30%, will have experienced discrimination in relation to accessing healthcare. As a woman of colour, when you're pregnant, you think this is an amazing thing. For most people, they'll celebrate it. For someone like me, or for my Black communities, they are frightened. It means 1 in 4 Black women may die in labour having a baby. For myself, it's 1 in 2. For my daughter, that means I have to be really worried and I have to change the system. That's not good enough. Stillbirth rates are really high, as we know. Mortality rates for babies of Black and Black British ethnicity at 43% higher than white ethnicity. Not good enough, I say. Not enough done, and we have to address this. In terms of the workforce, very little data is captured on ethnicity progression, retention in Wales, but you'll know from the data that Kit just shared, but that whilst we have 1 in 8 nurses from an ethnic minority background, we will have a much higher number of those that will be referred to the regulator, the nursing and midwifery regulator, on the basis of a fitness to practice. The 2019-2020 inclusion data from the NMC, I think it shows something like Black nurses made up 15.3% of fitness to practice referrals. Roger Klein, the research fellow at the Middlesex Business School, also reports highlights that 1 in 5 of all registered nurses and midwives working in the NHS from BME backgrounds will have a higher percentage referred to the NMC, and most are likely to suffer dismissal or suspension or very high impact decisions that our white registrants won't see the same. Professor Elizabeth White and colleagues' report, which is an excellent report if you haven't had a chance to read it, says ethnicity is related to the risk of referral to the NMC. That was quite stark to see that in writing. Black nurses and midwives, as well as those of unknown ethnicity, are disproportionately represented in the population of referrals to the NMC. And having qualified in Africa, as opposed to other continents, is a really high risk factor for referral to the regulator. These are shocking statistics. One doesn't expect to see this. What are we going to do in Wales around some of this? So my CNO priorities for the first time will be launched on the 8th of April. The vision that I have around my CNO priorities are not just a set of priorities. They will strive for a workforce which reflects the populations and the workforce we serve, and really work to address the inequalities that have been laid bare, but take some radical action to address it. I have 5 priorities, but one of those priorities for the next 2 years will focus specifically on professional equity and healthcare equality, under which, and I think I've been quoted before in one of the Nursing Times saying, I'm intolerant and I will not accept any form of discrimination or inequality for employees or patients. I want to address it, and I will take radical action to make sure that we all have a fair and equal chance at what we're trying to achieve and what we're trying to do. One of the key actions for me is to develop strong links and a network for ethnic minority nurses and midwives who have clear links through to me as a CNO. So there's a voice that I can hear it. I know what's happening on the ground floor. I don't need any more data. We're awash with data, but I want to be able to have a group of nurses, registrants who can have a link to me as a CNO so that I can hear it and I am spurred into action for them. There are activities to improve inclusiveness and an anti-racist approach in the NHS. Great, we have a great workforce strategy that HEIW has set. Social Care Wales have also got a workforce strategy. They were launched around 2020. It talks about plans for transforming and sustaining the workforce for the future. I say fantastic. I want to see where the focus for that workforce strategy is on improving the diversity, inclusion, capability of the health and social care workforce. How do we underpin that? I will push and I will challenge on your behalf. I will make sure that we are addressing what needs to be done. I've started off supported a few senior leaders in Wales to enter into the sponsored equity sponsor program. We have a couple of leaders on. The plan is to implement a similar type of leadership and progression pipeline for our ethnic minority staff, to provide the minority networks, ethnic networks, but to help with a sponsored equity program, which helps you to be a leader, helps you to progress, helps you to be the best you can be wherever that may be. I want to build networks with BINA and BAPIO. We've reached out to BINA Wales already and BAPIO. I'm meeting with the director of the Filipino Nurses Association shortly to understand what can we do to help to really drive change. I know that it's been 20 years. We celebrated only recently of our Filipino nurses being here. Whilst that was fantastic, I didn't think it was a celebration. 20 years without a senior Filipino nurse at any of our health boards, sitting in any leadership positions, is not good enough. I'm reaching out to the chairs and presidents of other African diaspora organizations, and I really want to start to understand how we can work together. We've got an overseas recruitment campaign that I set off and started on an all Wales basis when I arrived. It was already in place at many different organizations, but we pulled an all Wales approach together to consider ethical overseas nurse recruitment. What does that mean? We've got a great number. We've, I think, given nearly 80% of offers of our overall target. But this is not just about recruiting nurses to Wales. This is what's the reciprocal offer we can bring. What is the educational offer we can bring? How do we break through some of the barriers, identify the competencies, identify the skills, and recognize them? So not everybody entering our system enters at the lowest level, at the band 4, band 5, that we recognize it, and we offer the positions that are commensurate with the experience elsewhere. Since coming into post, I have been the lead for the health actions on the Anti-Racist Wales Action Plan alongside our workforce colleagues. I work closely with Welsh Government Workforce Director Helen Arthur, and I'm supporting, advising, and co-leading on the health actions. Our plan is centred on the priority areas in health and social care due to the inequities uncovered by the disproportionate impact of the pandemic on our ethnic minority colleagues and what they've experienced in the workplace. We're committed to implementing the actions identified, but we've not done that in isolation. We've worked with our valued NHS staff. We've asked questions. We've asked about how we can overcome what systemic and systematic changes we need to put in place to eradicate racism in NHS Wales. We've asked about the lived experience of people from Black, Asian, and minority ethnic backgrounds and used those to shape the goals and actions within the plan to address the areas of concern. And we've identified 5 priority actions. They focus on leadership, and I talked a little bit about that. But in addition to what I talked about, we're really keen to put together a succession framework that identifies you with talent and skill early on, that brings you and offers you opportunities and stretch assignments, offers you exposure opportunities from the CNO to other health boards, even across the border into other countries, really enable you to get a footing on the ladder. Workforce policy review is second. Workforce data quality is incredibly important. If we can't see it, we can't change it. And if we can't change it, it's because we can't count it. We have got to have the data that tells us the story to enable us to take the actions. And you will know that I launched a maternity and neonatal safety support program around health inequalities when I arrived in post. So a couple of months ago, the minister announced the program. I met with, in developing this program, I didn't do this in a dark room on my own. I met with our community groups. I met with our workforce who have had babies in our hospitals and asked, what has it been like? What's been your experience? And they have shared quite openly. It has not been good. Some of the report is harrowing to read. Some of it makes you sit back and just take a moment and a breath and realize how deep the inequalities, how deep unfairness and injustices run. But we've taken an opportunity to do something about it. We've pulled together our community group. We're appointing a team of people. We've got a bit of funding, and we're about to set off our maternity neonatal safety support improvement program to really focus on what we can do together with our communities to make pregnancies, birth, and babies coming into this world much more safer. I've said it before and I'll say it again. The children born today in our Wales are our future leaders. We have to give them the best start in life. We cannot continue to perpetuate and be part of the problems around children being born 3 down. Not acceptable. We have to help to be part of that solution. I will stop there, but the last thing I would say to you is, when I thought about what is an anti-racist Wales, we have this plan, so what does it look like? We have all of these actions, we have all of these goals, but what would it really look like? What will make the change at government level and within organizations? And I'm minded to quote Ibrahim Kendi, if any of you know, he wrote the book on how to be anti-racist, I think it's called. But he says, to be an anti-racist is a radical choice in the face of history, requiring a radical reorientation of our consciousness. So there are many things I can say about what it would be like and what it would feel like to be and work in and live in an anti-racist Wales. But I really think we are, and we should be, the change we want to see. So I can't do this alone. I have huge ambition and huge plans for the future, but I can't do it alone. I need each and every one of you. I need the workforce, and I need people like Kit and Zed and Catherine to be alongside me and help me to make the changes that don't always seem to be very obvious to those of us that look around and are living with some of the experiences we see. So Zed, I'll stop there if that's all right.
Really excellent. Difficult to listen sometimes, but very excellent. Summarize all the key things that we really wanted to do. I just wanted to quickly ask you in terms of your time, because we wanted to do a short panel before you go. Do you have 10 minutes?
Yeah, absolutely. I think I have until 2 o'clock, so I'm okay.
Okay. So just also to highlight, I think, to Ian, if it's okay, Ian, I will move your time to 10:02 so that you finish at 1:15, and then we can claw back time at the end as well. We don't need as much time to sum up at the end. So we will have an opportunity now to have a short panel so that people can ask you questions. I've got lots of questions for you. But what we were hoping to do, I think one of our panel members hasn't managed to join, who was going to be an external panel member, but I know Ian is here.
She's here now, Zed.
Huh?
She's here now.
Dorcas is here, okay, right. So we will try and shoot and use 10 minutes to have some questions. I think while it's quite burning in your thing, I will direct the first question to you, Sue. Really, the question I'm trying to find out, should there be greater efforts being made to capture diaspora staff's experiences from other health systems to benefit the NHS? And if you feel that this is the case, how do you think we can best do that?
Thank you, Zed. So yes, I think it goes without saying. I think what we fail to recognise in our NHS is the value and the absolutely rich experiences that our diaspora workforce bring. There is a misunderstanding that it is an immature workforce. It's a workforce that come from abroad with very little experience, and that is a myth, and it needs to be busted. And I think the way in which you address some of this is that you have to find a way to recognize the skill and the talent and the experience that comes from abroad. You have to find a way to be able to understand that the different landscapes lend themselves to our context. And I'm not sure that people will understand that. And I'll give you an example. I asked about international recruitment when I first started, and I said, what I think we need to do, we struggle to appoint in rural areas. I've come from Africa. I understand rurality. We do that really well. You know, I've been a community nurse for many, many years. I know that. So let's, I don't want to go to countries that can't afford to, but places where they can. Why don't we recruit for that richness? And I was told, no, nobody understands our community context like us. And I just think if I was allowed to say bad words, I would say a bad word, but I'm not, I just can't. I say nonsense, quite frankly. Nonsense. So what we don't understand here very well, and we've created this rhetoric which is unhelpful, and this narrative that says only us in Wales, only us in the UK will understand our patient population and our context. Now, some of it will be different. I completely understand that for someone who's come from abroad, but most of it, patients, conditions, pathways of care, comorbidities are pretty much similar. Practices may differ, standards may differ, but I think we have to start a conversation about these are the experiences that we can have, and we have to take some risk, and we have to bring those diaspora experiences into our workforce.
Thank you. Dorcas, hopefully you can open your mic and your camera so that we have recognized that there's an increased awareness of significant contribution of the diaspora, but we get the impression there's very little involvement of these groups in the organization that actually set the global agenda. From your experience, what is the reluctance? And also, are there specific barriers which makes it difficult for this group to be utilized in that way?
Thank you for having me, Zed, and thank you for this important conference. Zed, I am a nurse, I'm a mental health nurse, and many years ago, I went to Zimbabwe. I went to Zimbabwe because I'd been given a post by the Mayor of London, then Boris Johnson, to look into a program looking into young people who are involved in gangs and high exposure to violence in London, an important piece of work. I went back to Zimbabwe because I knew I needed to take some lessons from a culturally adjusted model, looking at mental health interventions in low-income countries, and apply those lessons to my population in Westminster and London. My population was largely Middle Eastern, African, and Asian. They were excluded communities. They were hard to reach, in quote, and I needed to execute some innovative engagement techniques. I worked with Dixon Chibanda and I came back to Westminster. And for the first time, a nurse was able to provide evidence-based and directional travel in terms of evidence-based interventions. We could knock on these doors. We could make a difference in minority communities, and we could provide evidence-based that we can take lessons from low-income countries into high-income countries. We are where we are today in terms of youth violence and providing a public health framework around this piece of work because of some of those lessons that we took from low-income countries into high-income countries. This is brilliant. This is Britain at its best. But who wears the badge of that evidence base? When I came back to the NHS, there was absolutely nothing to evidence that work into my own progression. It was 2 weeks of research in Zimbabwe and an execution of work in Westminster. And yet here we are. I'm not the only one. There are many of my colleagues, midwives and nurses, doing amazing work, often on their holidays, teaching in their home countries, coming back to the NHS with absolutely no validation. Now, you raise a great point. Where are the obstacles? Where are the issues? There's a reluctancy, Zed. There are issues here, let's be absolutely clear, of who wears, who owns, and who embodies knowledge. Knowledge is much more valid when it's white, British, and sometimes male. My colleagues who go to Malawi or go to Myanmar for 1 week and spend literally 1 week from a white background will come back with much more validation than my colleagues from the diaspora who go back to those home countries. And we know that they're doing that work. Let's be abundantly clear. We've done a lot of work in terms of inclusion on the front line. And we've said, well, look, we've got a lot of diversity on the front line, but that's not finding its way to the leadership in any way. Please wake me up one day when we have an African CEO who is actually working in the NHS in England. I haven't seen that. And yet our people are holding the front line in terms of BAME communities. This means a lot to our population and our communities. So I think there are a few things that are still standing in the way. Our reluctance to coin this and nail this as it is still in the way. We are still not nailing this as a leadership program. Now, there are also issues around us and some of the work that we're doing around mentoring and developing new leaders who embody this leadership, which is around mentoring. We too in the BAME community must identify ourselves as leaders. And we need support to do that because somehow through our history of inferiority and slavery and all the history that we have, we've somehow, some of us have said, we stop at band 5 and that's where we belong. And if I can send money home, and that's about it. But there's a lot of work to be done around middle management, supporting that belt. And most CEOs are hearing this. So we have work to do then. What is the cost and what is the loss? We are losing out on a lot of innovation. We are losing out on a lot of work we could be doing in climate change because we can take some of those lessons from the very good diasporas. And I want to acknowledge lastly some of the great work that is happening. Thank you to Thet and Ben and Kit and some of the work that's coming out of these organizations to afford, and many other organizations that are pushing the agenda. But we have work to do. Thank you.
I know we are running out of time, but just Ian, I know you might cover it in your talk. One of your big passions is leadership development. And some of these themes are not unique to what's happening there. In your way in dealing with international medical groups, do you see any stumbling blocks in some of these groups progressing in terms of leadership from your fellowship programs that you are doing?
Thanks very much, Seth, and thanks so much for inviting me to talk to you all today. It's the passion in the room and the innovation is wonderful to see. I think and I can only really speak for doctors, I'm afraid, because I am a doctor and I do work within the medical deanery of HEIW, and I have very little expertise on other health professionals. But I think we are rather behind, I think, in terms of developing all doctors as leaders. Traditionally, we've not been very good at developing formal programs, doing that talent management, doing that succession planning for doctors that perhaps other healthcare professionals are slightly more ahead of the curve with. So, we have been doing a lot of work over recent years trying to specifically look at developing our doctors to become leaders in the future and take on more sort of formal leadership roles. So we have the Welsh Clinical Leadership Fellowship that you mentioned in your introduction, which is available to medical trainees, dental trainees. And over the last couple of years, we've also extended it out to other healthcare professionals because we saw the value of developing leadership programs multi-professionally. So there's that strong element of interprofessional learning. So over the last few years, we have extended it out to optometrists, to pharmacists, to allied healthcare professionals as well. And I know there are ongoing conversations, seeing Sue on the call, of looking at developing that to complement some of the opportunities out there for nursing, such as the Florence Nightingale Fellowship and various other things. There has been a real challenge over the number of years that I've led the Welsh Clinical Leadership Fellowship in terms of recruiting trainee doctors from Black, Asian and minority ethnic communities. However, over recent years, we've started to see a shift. We've seen an increasing number of our fellows coming through from who are international medical graduates, who are from Black, Asian, minority ethnic communities who have qualified in medicine from the UK. So there is that shift, and that's got to be it is the tip of the iceberg, unfortunately, but that's got to be the most important thing. The more we have these positive role models who are going and doing these leadership programs, then taking on formal leadership roles within the NHS, that's got to hopefully, open the floodgates in terms of more of these, more of colleagues from international medical graduate backgrounds and BAME backgrounds taking on leadership roles. Within HEIW, we have our strategic equality plan, and there's been lots of work going on right across all of the areas of HEIW, specifically in the medical deanery, looking at how we can actively, look through that lens of equality in everything we do. So there is a lot of work to do with regards to trying to encourage more colleagues from international medical graduate background, BAME backgrounds into leadership fellowships, into leadership role. But I think we've started those first steps now, and I'm keen to work with colleagues and partners from this forum and from across Wales to see how we can do more to improve recruitment into leadership roles for our IMG and Black, Asian, minority ethnic colleagues. So small footsteps, but we've got much to do.
Thanks very much, Ian. I think some of these topics we can explore a bit more in the breakout groups. I just want to give Sue a last say before she runs away, whether she wants to comment on some of the things that have been said, because I know you are going to be going away before we listen to Ian just now.
Yeah, no, thank you. So absolutely moving. So Dorcas and Ian, I think both have shown a huge passion, and I think Dorcas is absolutely spot on when she says we have to call some of this out. We have to give it the right language. Language is power. We all know this, and sometimes we skirt around the edges. And I think it's high time we we called it for what it is, and then took the actions to really make a difference. I think I hear the passion, which is great, but I have been hearing the passion for 25 years. And so I think for me, this is a start of a change. And I really, truly want to see tangible differences for our workforce, which ultimately brings better outcomes for our patients. That's where I want to get to. When I step off in 5, 6, 7 years, when I retire, I don't want it to go back to the way it was. I want to find those absolutely talented stars coming from diaspora countries who have so much talent and experience to bring, that can step into the next CNO role, if not in Wales, then in England, then somewhere in the UK. But I want to see that. And that's the legacy I wish to leave, Zed. So, huge challenge. But I think, we're all saying lots to be done. I think let's get it done is what I would say. Let's do it. So that's the last word.
No, we are all going to support you. Thanks very much. We know you're very busy, and thanks for your time. Thank you.
Thank you. Take care. Bye-bye.
Ian, over to you.
Thank you very much. I'll just share my screen. So bear with me. Now I seem to. Oh, here it is. Brilliant. So once again, thanks so much for inviting me to speak with you today. Now, I've been reliably informed in my sort of pre-conference briefing by Zed that I have 15 minutes for this presentation. So I will endeavour to stick to time. As I said during that panel discussion before, I am a medic. I'm a psychiatrist by background in Swansea, and I'm also the Director of Medic Support and Development within the Medical Deanery of Health Education and Improvement Wales. And I was asked here to talk about what we're doing as an organisation, specifically to talk about international medical graduates. Now, I appreciate this webinar is related to all healthcare staff, but my area of expertise is mostly on our medical trainees and SAS doctors in Wales. So I am going to be talking primarily about international medical graduates in the next few minutes. But I think it's reasonable to say that a lot of the themes that I talk about do apply to healthcare professionals whose primary qualification is not from the UK or from the European Union. So hopefully those of you here today who are from backgrounds of other healthcare professionals, those will resonate with you. So as already been said, with regards to doctors, they make, particularly doctors from international medical graduate background, they make a huge proportion of our medical workforce in Wales. Zed mentioned 1 in 3, which is about right. This is the GMC data, relatively recent data on the proportion of international medical graduates across the different health boards of Wales. And as you can see there, it ranges from 10% in Powys right up to over 40% of doctors in Hywel are from international medical graduate background. So it's a significant proportion of our workforce, and obviously something we need to take very seriously. And I think there has been a lot done with regards to supporting international medical graduates in Wales. And again, I can only speak from the Wales perspective, not the UK perspective, but I think there is huge amounts of work and progress that still needs to be done. And why is it important? Well, we're still, unfortunately, in the middle of a pandemic, and we're increasingly aware of this concept of differential attainment, which I will talk to you about near the end of my presentation. But thinking about the impact the pandemic has had on Black, Asian, minority ethnic doctors, on international medical graduates, you can see here the impact that the pandemic has had on those groups. One of the great, if you can say great, if that's the right term to use, one of the things that we've really cherished, I think, from the pandemic is how teams have come together. And the majority of doctors and other healthcare professionals feel that. But even within international medical graduates, Black, Asian, minority ethnic doctors, there's a huge differential between their experiences related to teamwork in those top two bars there, and those of who are white doctors. Going right to the bottom, mental health and well-being, a differential, significant differential between BAME doctors and white doctors. And if you look at all of those different descriptors next to those bars there, you can see there's a huge differential between the experiences of international medical graduates, Black, Asian, minority ethnic doctors, and white doctors in the UK related specifically to the pandemic. So there are huge challenges and huge questions we need to answer and find the solutions to start really, sort of developing that parity really of experience and that equality of experience. So what I wanted to talk about briefly today, and I'm conscious that probably only have 10 minutes now, I just want to do a really quick whistle-stop tour of some of the things that are happening within Wales to support international medical graduates. And I want to talk about a Train, Work, Live campaign, something called Welcome to Wales, medical training initiative, which is a particular scheme that is not unique to Wales, it's across the whole of the UK, which offers doctors from low and middle income countries the opportunity to come and train in the UK and take those skills back to their country of origin. I'm going to talk to you about SAS and locally employed doctors. Now, I'm aware the nomenclature here might be unfamiliar to some perhaps on the call. So what do I mean by SAS doctors? Well, SAS doctors are those doctors who aren't consultants or in formal training programs, but we have a significant proportion of them in Wales who work as very senior doctors, but they are not at consultant level or in formal training programs. That's what I mean basically by SAS doctors, and the same really for locally employed doctors. A significant proportion of our SAS doctors in Wales are have an international medical graduate background. I want to talk about some of the work we're doing across the system, because this is not just up to HEIW to address as the the statutory education body in Wales. This has to be, solutions need to be found to some of these challenges across the whole system in Wales. And I'm going to talk to you about some of the work we're trying to do across the system in collaboration with the health boards as well. Particularly pertinent, I want to talk about the ward group, which is the Wales Asylum Seekers and Refugee Doctors Group, particularly pertinent currently at the moment. And I also want to touch on differential attainment. So one of the great successes in recruitment over the last couple of years in Wales is the Train, Work, Live campaign. This is led by a colleague of mine, Hilary Hopkins, in HEIW, and it has had a significant impact on recruitment, both of doctors from the UK and the European Union, but also from doctors from across the international community, international medical graduates. Now, increasingly in many of our specialty schools, in many of the areas that we train doctors in Wales, we're having a higher proportion of international medical graduates coming to train in Wales than graduates from the UK or from the European Union. And the Train, Work, Live campaign has been a huge part of promoting Wales as a place to come and not just train and develop, but also to work and to live. It's the whole kind of the USP of the Train, Work, Live campaign. It's not just saying how great it is to come and train in Wales. It's also talking about working and living in Wales and what the advantages of that are as well. And take my specialty, for example, psychiatry. When in my previous role as head of specialty schools for psychiatry, we had huge challenges with recruitment to junior psychiatry training positions. We were recruiting on average 50 or 60% of our core psychiatry training scheme, which, it wasn't sustainable in terms of, developing the psychiatric medical workforce of the future. And as a consequence of that, we really got on board with the Train, Work, Live campaign. We did a lot of work with Hilary and her colleagues to promote psychiatry, both within the UK, promote psychiatry training in Wales, both within the UK and across the world. And over the last couple of years, I'm pleased to say we've had 100% recruitment in Wales into psychiatry training. So the Train, Work, Live campaign has had a huge impact on recruitment to many of our medical specialties in Wales. And it has also had an impact on nursing and midwifery and pharmacy, as you can see. And I'd really encourage you to have a look at this website. Just Google Train, Work, Live. There's huge amounts of resources on the website. It's been a really positive program to promote Wales on a kind of global basis, really. In addition to that, we are conscious that, as I've already shown you in that second slide, we have a significant proportion of graduates that come from international backgrounds, and we are in the final throes now of creating this revised document, Welcome to Wales, because the impact of moving to a completely different country can never really be understated. And it's not so much the impact of coming to work in another country, because we have doctors come from all over the world. They are trained doctors. They have the skills, the practical skills, the knowledge, the expertise to work as doctors. But what they don't have is the awareness of the country, the context they are coming to. And this Welcome to Wales booklet, which I'm hoping will be launched imminently, it's going through the final iterations, covers a range of topics, and it's particularly targeted at doctors, and there's no reason why it couldn't be used and utilised by other healthcare professionals in the first few months after arriving in Wales. Loads of useful information, not so much related to working in Wales, but all of the other things that you need to think about when you move to Wales: how you secure accommodation, how you organise healthcare, what the situation in Wales is with regards to taxation and some of the colloquial terms used in Wales. Lots of really valuable information, which will be contained in this Welcome to Wales e-booklet, which will be continuously updated. Likelihood is it will be developed into an e-resource as well. And I would commend that to you, because it would be a really useful resource that we're going to be launching very, very soon. Medical Training Initiative. Now, this is a unique scheme within the UK. It's not just Wales, whereby doctors from other countries are able to come to the UK and train for 2 years, develop skills, develop knowledge, develop expertise before returning to their country of origin to, utilize those skills and that knowledge that they've developed here in their own countries. And interestingly, before the pandemic, we had about 120 doctors from various countries, mostly low and middle income countries, though we do have quite a fairly significant proportion of doctors that come from Australia on the MTI scheme. But now, unfortunately, probably related to pandemic, probably related to some of the challenges with regards to, during the pandemic, of challenges related to international travel, we only have currently 38 medical training initiative trainees in Wales. And we're looking to increase that, obviously, back to pre-pandemic levels. We have doctors from all over the world who come to Wales on the Medical Training Initiative. The top countries there are listed in that second bullet point there. And we have them working in a range of clinical areas, but most commonly medicine, surgical specialties and pediatric specialties. One of the big challenges we face with the Medical Training Initiative in the UK, not just across Wales, is the ethics of the Medical Training Initiative. We talked about ethical recruitment earlier, the importance of ethical recruitment. You know, it's so important that when we develop global relationships, they are done with, you know, a high level of ethics and corporate responsibility. But increasingly, we're finding that doctors that come on tier 5 visas, which is the specific training visa, they come for 2 years, are increasingly moving to tier 2 visas whilst they are with us and remaining in the UK for a significant proportion of time. And, you know, that's great, but that has an impact, a huge impact potentially on their country of origin, because we don't want to preside over a sort of brain drain from those countries, particularly as our scheme is about developing skills and then those skills being able to be shared back in their country. So there's a lot of work required, scrutiny required regarding the Medical Training Initiative, and there's lots of work going on a 4 nations level looking at that. And obviously within Wales, we're currently doing a lot of work trying to put in more governance, trying to put in more support and education for our MTI trainees in Wales, and also considering whether we as an organisation, Health Education and Improvement Wales, should take on the role as GMC sponsors for MTIs and also tier 5 visa sponsorship as well. As I mentioned, our SAS doctors, about 1,000 SAS doctors across Wales, significant proportion of them are international medical graduates. We have been committed over the last couple of years within Health Education and Improvement Wales to make the SAS career pathway just as an attractive career pathway as traditional training routes. And as a consequence of that, we've put a number of things in place to support SAS doctors across Wales, particularly those SAS doctors who maybe are looking to progress with their career with regards to specialist registration and becoming consultants through the CSER route. We've developed a CSER support and advice line. We have a network of doctors from across Wales who've already successfully achieved CSER and are on the specialist registration, who are acting as support and mentors for doctors from their specialties who are looking to embark upon the CSER route. We are very keen that our SAS doctors right across Wales, and again, you know, I'd just like to emphasize a large proportion of these doctors are from international medical graduate background. We are very keen that they have the same access to educational opportunities that doctors in traditional training pathways have. And we've been doing a lot of work across the system with health boards, with specialty training schools to ensure that that equity is there, that we've leveled up the playing field or are leveling up the playing field to ensure that our doctors in SAS grades have that access to educational opportunities. We're very excited currently to be working with the General Medical Council in Wales, particularly with our leadership fellow who's working in the General Medical Council, Blanche Lum. She's currently working on a project exploring the culture and morale of SAS doctors, because we know that there is significantly lower morale in SAS doctors who have been SAS doctors in Wales for a long time, who are male and who are primarily who have an international medical graduate background. And it's really important that we do that piece of work to understand what's happening in that subset of doctors working in Wales, and Blanche is leading that really important piece of work, which no doubt when we have the results of, I'd be very happy to share in the future with this forum. As I mentioned, it's not just incumbent on HEIW to be doing all of this work, because this needs to be a system wide approach. And one of the two of the big areas that I think we really need to get smarter at and better at in Wales is induction for international medical graduates, and also ongoing support for international medical graduates. It's just not good enough that historically, our international medical graduates would arrive in Wales and literally have a one-day induction to working in the NHS. Absolutely not good enough. And this is why we've set up this expert advisory group, which has drawn membership from across the NHS in Wales, from various international medical graduate colleagues, from colleagues within HEIW, to look at how we can improve and what we can do to improve induction and support for our international medical graduates in Wales. And I'm just not able to see the side of my screen because of all your lovely faces. I'm just going to move them slightly. So what the aims and the objectives of this expert advisory group is to focus on induction, to focus on ongoing support for international medical graduates, to share. There's lots of good practice going on in Wales, and there are lots of pockets of good practice going on in Wales. And I think there's just not enough of sharing of that good practice across the system in Wales. And what this expert advisory group is looking to do is to look at that good practice, to share that good practice, and also to develop some direction, some strategy and action plans for how we can improve induction and support for our international medical graduates across Wales. Coming to the end now, I'm sure you'll be glad to hear just a few more minutes, if I may, because I think this is really important that I talk about the Ward group. This is the Wales Asylum Seeker and Refugee doctor group in Wales that actually has been running since 2002 and is jointly managed by Leona Walsh, who is our manager of the professional support unit in Wales. And the Ward group supports healthcare professionals arriving in Wales as asylum seekers or as refugees to develop careers within NHS Wales. So as you can see there, we support healthcare professionals, majority of which have been doctors, actually. We support healthcare professionals through professional registration. We support them through the examinations that are required to practice within the UK. And we even provide posts, supernumerary funded posts that we fund ourselves to support those doctors and other healthcare professionals to be integrated within the NHS workforce. And so far, roughly 250 plus doctors and other healthcare professionals have benefited from this support since the inception of the Ward Group in 2002. And here is the email address there of our professional support unit if you wanted to find out more information about the Ward Group, which I'm sure Leona would be delighted to share with you. Finally, just before I finished, and actually I could spend an hour, I could spend a whole day talking about differential attainment, because it is a huge challenge that we need to address. And what do I mean by differential attainment? Well, what I mean is, and again, talking about medics, but this applies to all healthcare professionals. Differential attainment is defined as, attaining differentially based on your ethnicity, based on the where your primary medical qualification comes from. And we can see huge gaps in exam pass rates in professional examinations, for example, in recruitment, in overall satisfaction, in progression, based on ethnicity and location of your primary medical qualification. And going back to what Sue said before, this is just not good enough, and we need to do better to close that gap. And we've been taking this, very seriously in Wales over the last couple of years. Colette McNally, one of my colleagues within HIW, has been leading the work on differential attainment. There's lots of things going on related to mentorship, extensive packages of education to support and to narrow the gap of differential attainment, which we see in many of our medical trainees across Wales. So, hopefully being able to share some interesting information with you this afternoon. International medical graduates, international graduates in all healthcare professions make up a significant proportion of our workforce in Wales. And fundamentally, we've done a lot, but we need to be doing much, much more to support when they arrive, through induction and through ongoing support and development. So I will stop there. Thank you so much for inviting me to speak. And over to you, Zed.
Thanks, very comprehensive and very detailed. And I think a lot of the things that you covered probably are things we were going to ask you a lot about. We really need to see if we can give people maybe 3 minutes break, a comfort break. Can we come back at 23 past? We are going to take most of the time from the session that was supposed to be mine. So I'm hoping that most of the other sessions can still go ahead. So if we come back at 23 past, and then we can listen to Bernard and Fiona's team. Apologies, we are running a little bit late, but I think all the topics have been so interesting and important. So 23 past, if we meet.
My name is Bernard, and I am with our clinical service lead, Dr. Fiona Ray from the Betsy Kenya Health Link. So maybe can I just give Fiona the first few minutes to introduce herself and the link, and then I'll pick it up from there. Hi, Fiona. I think you're muted, Fiona. I can't hear you.
No, we can't hear you. That's strange. We could hear you before. Oh. Let's try it without the headphones. Having a technical hitch. It was due, so everything else has gone fairly smoothly. Well, Fiona, we can't hear or see you now. Bernard, are you okay to carry on, and hopefully Fiona will come back with us at some point?
Maybe, yeah, I can't seem to hear Fiona. Maybe do you want me to carry on?
Yeah, you can continue.
Okay, so if I can go to the next slide, please. So a bit of history about the Betsy Kenya Health Link. So this is a partnership between Betsy County Referral Hospital in Kenya, which is in East Africa. So the partnership dates back to 2019. And it started when a team of Kenyan diaspora who are based in Wales, together with their colleagues from Betsy Kadwala, that made a formal visit to kind of kickstart the initial engagements, get to know each other through that initial meeting. If you could flip through the pictures, please. So what you're seeing on the screen is the team of volunteers that traveled to Kenya, know the situation on the ground, and kind of trying to make initial engagements or when the team met with the health management team in Busia. And if you move to the next picture, please, I think this one picture that was taken with the county government officials in Busia County government. So just to kind of highlight what the journey has been for this health partnership. Next slide, please. And that is a picture between the team and the governor of Busia County. Thank you. Next slide. Yes, so during that initial visit, there were a few outcomes that were recorded, and one was, apart from that initial introduction and just getting to know each other. So there was a preliminary needs assessment that was conducted to try and understand what are the key issues in Busia County that then the health partnership could move forward in terms of its focus and trying to find ways through which they could support the team in Busia and engage on moving forward. There was also teaching on clinical skills, and this was two ways. So the teams that went there were able to learn something from their colleagues in Busia, and the clinicians in Busia were also able to learn something from the team that traveled from Wales to Busia. And that has been one of the strengths of the partnership at those initial stages, that there was that kind of relationship that we managed to establish between our teams on this in Wales, as well as the teams in Busia. Then lastly, there was a memorandum of understanding that was signed just to kind of formalize the partnership, which was really a quick turnaround if you consider that they
Did we lose sound there?
Sorry, Bernard, we missed that last bit. We lost the sound.
Sorry, so I hope you can hear me now. So the other outcome was a memorandum of understanding that was signed between Betsy and Busia County government, just formalizing the health partnership and outlining some of the key areas of cooperation that the partners would engage on moving forward. Next slide, please. So a bit of details about the Memorandum of Understanding signed in 2019. First, it aimed at building the capacity of health workers through shared learning. And part of that was already taking place at the time of the initial visit. And then the second aim was to improve the quality of healthcare across the two partners. And then there was an issue with data collection that was identified during that initial visit and was agreed as a good priority for the partnership to focus on. Lastly, was about reducing barriers to healthcare access and reducing inequalities, so to say. Thank you very much. Next slide, please. And so on the basis of that memorandum of understanding, the partners started working and trying to address some of these key priorities. But the first thing that they really wanted to do was kind of get a deeper understanding of what the issues that were initially identified were. So, and to do that, we decided to do a comprehensive health needs assessment from 2019. So this was based on the preliminary health needs assessment that was conducted in 2019. And then, so the team was engaging in just trying to kind of collect more information about the priorities that were identified. And in terms of the members who were on the team, it was quite a diverse team that was engaged at that time, involving different cadres of clinicians and non-healthcare, clinical professionals who were part of the link. But it was a mixture of Kenyan diaspora based here in Wales, together with other clinical team members from Betsy Kadwalada. So we scheduled to complete the comprehensive health needs assessment in May of 2020. But as you are all aware, around the start of 2020, the pandemic was here with us, and that kind of disrupted a lot of the plans that we had, and we had to start looking at what other alternative or how else could we go about the comprehensive health needs assessment, as it was critical for the health partnership moving forward. So we kind of had to reconsider the process, because initially a team of volunteers was to travel to Busia again, but that was not possible due to the travel restrictions that were in place then. Next slide, please. So with our revised approach, we focused on remote data collection, try to look at the published information about Busia County, and the reports that they were producing on a time-to-time basis, and trying to understand what the health priorities for Busia County were. And we did this in consultation with our partners in Busia. So we had those periodic meetings just to engage and catch up and review some of the information, so that we can, it's up to date. And then the next step was around working on capacity building the volunteers on in Busia County, so that then they could support us in undertaking the comprehensive health needs assessment, especially those components that required primary data collection that we couldn't travel to Busia to do it ourselves. So we built capacity for the healthcare workers on the ground, and then subsequently managed to conduct stakeholders consultative fora that brought together key persons that we initially were targeting for the health needs assessment. Next slide, please. In addition to the health needs assessment project, we had a Shillings for Sheets campaign that we ran in 2020, towards the end of 2020, and this was funded by the Welsh government, together with funding supplemented from fundraising activities undertaken by the volunteers. So the pictures you see are for one of our volunteers, Jen Ross, who is also our project manager in Betsy Kenya Health Link, and she was climbing Snowdonia together with other volunteers just to try and raise some funding, which was purposely to be used for purchasing linen that was going to be used in one of the hospitals in Busia County, and this was based on what the team observed when they went to Busia County, as a few or most of the patients didn't have a linen on their bed. So one of the interventions in the short term was just to try and help them or support in terms of procuring additional linen for the referral hospital. Next slide, please. In 2021, last year, we managed to secure some additional funding from the Welsh government, about £15,000, and this was to be used for COVID-19 response. And the project that we chose to undertake was community events-based surveillance, in which we built the capacity of community healthcare workers with making sure that they are able to conduct risk assessment in the communities, identify any risks when they occur, flag this risk to the public health response team so that they can then prevent outbreaks from occurring, as at that time there was a high risk of community transmission and a lot of cases were being reported. So we've been implementing this project. I think it will be coming to an end in a few months, but the outcome has really been good, and we've had very good engagement with our partners on this. Next slide, please. So some of the key achievements for our community events-based surveillance project were around, we managed to train 68 community healthcare workers on events-based surveillance. And this involved 3 training sessions. So we exceeded our original target of 10 community healthcare workers who wanted to initially train, as there was a very high uptake at the time of delivering the project. We managed to establish an events-based surveillance system that is currently running, and through the system, a lot of signals have been reported or flagged out, and this just helps them to kind of improve on their reporting so that information flows really quickly from the community, from the communities in so that the public health response teams then can get this information quickly and act on them and help prevent any outbreaks in the community. And then so far we've managed to reach 645 community members, 273 respondents that we've had in our baseline survey as part of the project, which we are currently analyzing. We've managed to do a media release, which was really good in terms of helping us to kind of publicize our link. Next slide, please. In terms of challenges and advice for any new or potential partnerships. So some of the challenges that we've seen over the past 3 years that we've been engaging with our partners, one is around personnel constraints, competing priorities, limited funding for our activities, connectivity issues. And then in terms of the advice that we can give to any new or potential partnerships is just to encourage you to kind of take up on networking opportunities with other established health partnerships. There's more to learn from already established partnerships, and there are quite a number of forums that you could be able to link up with them. In terms of engaging volunteers in the health partnerships, our advice is just around making sure that we sensitize potential volunteers so that they are aware that these health partnerships exist. And then shared learning, and then lastly is around making sure that the needs are clearly understood at the time of forming partnerships, so that you're more focused, because if you consider the challenges with the limited funding, then you just want to be sure that you are focusing on the identified needs, and you're not or you're not deviating from what the real issues are that you chose to focus on. I think that's the last slide, if I'm not wrong. Thank you very much.
Thanks very much. I think you all can realize that our time has really flown. I think you have had a terrible chair. So we haven't got, I don't think we have enough time now for breakout groups. But I think it's quite important that we should have allowed Bernard and everybody to share. They've done a lot of work, and actually a lot of what has been covered would have been covered in the breakout session. What we have decided as a group is we will use the last few minutes for an open discussion with everybody. People can raise their hand if they want to make a comment. And while you are thinking of your own comments, if you don't have extra questions here to ask Dorcas and Ian. The first one I'm going to be is for Bernard. Give us your experience, Bernard, in terms of being a diaspora group, how you have found all these linkages and how it has worked for you, and any success stories or times where you had a chuckle or times where you wanted to scream.
Yes, so thank you, Zed. I think as a Kenyan-based diaspora, one thing I would say is that I was very excited that there was a health partnership in place that was focusing on the country where I came from. So I kind of wanted to be involved in the health partnership, and it just happened that the people or the partner they were working with in Kenya is a partner that I also knew. So I managed to bring that kind of contextual understanding on board, and supported the partnership in terms of just making sure that we all engagements are flowing smoothly. In terms of what the biggest challenge, of course, is that running health partnership activities takes a lot of time. It takes a lot of commitment for you to be able to just keep on tabs with everything. And we know, like, living abroad, again, there are so many competing priorities that people will most likely tend to say, we've got other pressing matters, as opposed to getting involved in the health partnership. But if you've got passionate members, which is the case in our health partnership, people who are willing to make a difference back in the countries where they come from, then that makes a whole difference in terms of how the partnership performs in the long run. So, and with amazing support, of course, from our colleagues based here in Wales. And I don't know if Fiona is back on the call at this time. Yes.
I just wanted to follow that theme. Mark, I can see Mark Wallap. I know you struggled initially setting up your partnership. Do you want to share your experience and sort of the difficulties you had? Oh, maybe it's just a name. Are you there, Mark? Mark Walapu. Right, while Mark is connecting, can we have Kit? There's a question I wanted to ask you, Kit. I never got a chance. In terms of things that we can put for activities to help engagement, what can be put in place for diaspora engagement in global health activities? I know you're head of policy and everything. What are the sort of things that you think need to be put in place? Maybe capturing what has been said by Sue and Ian.
Yeah, and so I suppose it depends on the position that people are in. because clearly there are structural things. So I think introducing some way of recognizing, first finding out and then recognizing those diaspora healthcare staff who are already engaged in global health activities. Dorcas has said, you know, she would go and do things and nobody even knew, hardly anyone even knew about it, and then it wasn't recognized. So at an organizational level, having an interest in finding out and in recording that. And actually so I mentioned the diversity network that THET is starting up, and that's one of the things that we would like to do through that, working with the leaders of NHS trusts and boards and their BAME networks or diversity networks or whatever the term is in their organizations, to try and connect with people who are doing work and at least start to make a record of that, because surely the recognition for the work that's being done needs to start with an understanding of what's actually going on, and then making sure that is recognised, that if what those people are doing is contributing to their professional development, that is recognised, recorded, and championed, so that other people understand what they're learning and what they're bringing back, and finding out how that translates into their UK practice, and what there are probably many other things that they could be contributing to their organisations that their organisation is just missing by not looking for it in the first place, never mind finding it, never mind putting into practice or putting into place the structures that could support it. So I don't want to talk for too long. I could talk for much longer about that, but some initial thoughts on what could be done.
No, thanks. Mark, I think you are now on.
Yes, Zed, sorry, I missed that bit. I was out of the room, and when I came back in, I just heard you mentioning my name. What was the question?
No, we just wanted to hear your experience of setting up a network as a diaspora group, whether you found any difficulties. I was following up from Bernard's experience in trying to capture your experience, because I know you started right from the start and setting up an organization.
Yeah, I mean, Bernard's experience is quite impressive with the lady from Betsy as well, but my experience has been rather different. Mainly it's been with regard to taking forward a project and getting the necessary funding. That I found quite difficult, and also having retired actually is quite difficult as well, because you're no longer in the NHS, and I think the requirements of the Welsh government essentially is that you have to be working within a health board setting, as it were. So it's quite difficult in terms of trying to get resources to take forward the projects.
Oh, yeah, thank you. Just before I forget, we are going to finish at 3, but we're going to keep the link open between 3 and 3:30 or so for other people that want to have more detailed discussion and they just want to network. So we will not keep you after 3, but we will make sure that we are still open in case people want to have a bit more chit chat. Dorcas, you wanted to comment a bit more about that, setting up a network, and what is these barriers from the diaspora groups?
Thank you, Zed. First of all, to acknowledge that diasporas organize themselves organically anyway. They are very, very organized. They're very traditional in the way they come together. They often come together at crisis sometimes, and they're often very much responding to typically NCDs or, disasters or often climate change disasters. They organize themselves. There's this big need to help out back home. So they're already organically organized. There are a lot of local philanthropists that are floating between these circles. So India is very good at philanthropy, Nigeria is, many other local countries are. So we shouldn't think that these countries and diaspora groups are wholly dependent on our funding. They need it, it'll be great to have it, but actually they do quite a lot just amongst themselves. And I see that through £10 donations, £20 donations, it goes a long way in terms of those structures. And secondly, there are those who are already organizing themselves. Samu Sibanda is a lady, I'll pick out, a midwife in Northampton, NHS Trusts, who started her own partnership outside structures, started taking some midwives back home to Mpilo Hospital in Bulawayo in Zimbabwe. And today she is phenomenal. She has raised the framework to her own trust and said, this works. Can we work with this? And the trust is sort of responding to that. So I think that the baseline of where diasporas are coming from needs to be understood. But look, Zed, most of my most beautiful, intimate moments in working global health have come from observing just what is possible on the ground. There are many moments on the field when patients don't have any money to get home. They need $5 to get from Harare to Nyanga, and doctors and nurses will dig in their pockets. These doctors and nurses are earning less than $100, less than $200, but they will make that need and meet that need. The second point is on mental health. Our own NHS Work Trust is absolutely stressed and stretched in terms of output, particularly the front line. It's not unusual for me as an A&E nurse in Imperial to be nursing a fellow nurse and a doctor at 2 o'clock in the morning who's anxious and distressed, has taken an overdose. That is the cost we are paying in the NHS in terms of well-being. Now, where else could we look for lessons that are working in terms of well-being and improving well-being for our workforce? We can do that by going back to our own partners in low-income countries. They get this. They get this really well. They're very cohesive. They're very culturally cohesive. It's not unusual for doctors and nurses to say a prayer at the beginning of a handover. This brings us together. It's a bit like mindfulness in our own clinical environments. So there are many little missed moments, intimate moments, to me, certainly as a clinician, that keep me alive and keep me burning and keep me hungry to go back to that field, because it is exactly that field that we can extract lessons from. And when we can extract lessons from those areas and improve outcomes in our own populations, this is global health at its best, at its absolute best.
Ian, do you want to have the last word? What can we do to help you? We have all these doctors who come from Africa who say they need help, but we feel we have an obligation to help you, because some of us are in leadership roles. We have made it in this country. What can we do to pull the other people to help you to get things moving?
I think, I think I need to acknowledge I don't have all of the answers, and that's why I need networks like this to support the work we're doing with international medical graduates in Wales. Now, I know before I took up my post, actually, that we created a forum, almost an expert advisory group for international relationships that I don't think has been reconstituted since my predecessor was in role. So we need to have more of this networking. We need to have more of these forums. We are so used, and I'm afraid, we're particularly bad at it, a bunch of doctors. We're so used to working in silos, professional silos. One of the great advances of HEIW is we are now working as a bunch of healthcare professionals. Beforehand, it was doctors in one building, nurses in another building, talking about how you can educate healthcare professionals in the future. We need to break down those barriers. And I think having opportunities like this, developing more networks, more forums, sharing ideas, finding out about best practice, because there, as I said in my presentation, there's huge amounts of good practice going on right across Wales and right across the other 3 nations of the UK in terms of supporting our international medical graduates, our health colleagues from all over the world. And I think we need to get better and more efficient at finding out about that, what's going on, what's going well, and sharing that, but also, learning about things that haven't gone so well and learning from those mistakes as well. So I would really value, and I'm happy to stick my email address within, in the chat, because I do need to leave at 3 o'clock for another meeting, but I'd really value having further conversations with colleagues on this call, specifically about how we can support more effectively our colleagues who are international medical graduates. So again, thank you so much for the opportunity to come along.
Zed, you're on mute. Zed, you're still on mute.
I just wanted to apologize. I'm giving Catherine 2 minutes now just to do some closing remarks. Really, thanks for everyone for coming in, and really thanks to Beth and all the team from Hub Cymru Africa for the excellent work. Beth has done all the hard work, but I think Catherine will do a few closing remarks and reprimand me.
Catherine, you're on mute as well. Catherine, are you there? You're still on mute. I think we may have lost her.
Right, looks like we're having technical problems, isn't it?
Not just me then.
No, but we can hear you now, Fiona. Not always the way.
Typical. I've had better conversations on WhatsApp with a doctor in a hut in Kenya with a clearer link.
It looks like we probably have lost Catherine completely now. So maybe it will have to be just me saying thank you to everybody. And for anybody who is able to carry on from now on. And I've just been reminded there's a quick poll, please, if you can do that quick poll before we close the meeting, and just to get a bit of feedback. But for me, it's been really a very helpful conversation. It's quite clear that we put a little bit too much in terms of what we could cover in 2 hours. But I think a follow-up meeting will be a bit more organized, but I found it extremely helpful. And thank you to all the people that contributed. Thanks, Ian. Thanks, Dorcas. Thanks, Kit. And I know Sue will thank as well. And thanks very much, Beth. Anyway, for all those that are able to stay, let's have a continuous chat. But everybody else, you can go and start making tea now.
Thank you, Zed. Thank you, Beth. Thanks, everyone.